Iqbal, for your success with the little quiz that we run. We've started trying to put out a quiz in the weeks in between the sessions just to revise the content. We didn't quite get the renal questions out, but we'll send out the renal questions and the questions on pain screening after this session. And I'll just move on now and introduce Dr. Melanie Lovell so that she can give us her talk on pain and screening for pain and the benefits and challenges that entails. So Melanie is a Professor of Palliative Medicine, a Senior Staff Specialist at Northern Sydney, and a Senior Academic at the Palliative Centre, and an Adjunct Professor at the University of Technology in Sydney. Melanie was the founding chair of the Australian Cancer Pain Management Guideline Working Group and also leads the Cancer Pain Research Group at Hamrahi Care. So she has a long-standing interest in improving cancer pain assessment and management. And we're very fortunate to have Melanie presenting to us tonight and talking through not just the if you like the reason to do pain screening, but what are the benefits and what are some of the challenges that presents for clinicians, and perhaps, I'm not sure if you'll go into some of the research areas as well, but we're very happy to hear what you would say, Melanie. And I think you're happy also to take questions as you speak. So if people do have questions, please just raise your hand and Melanie will try to respond during the talk. So over to you, Melanie. Thank you.
Thank you so much, Odette. I'll just share my screen. Yes.
Are you able to share it, Melanie?
Yes, are you able to see that?
Yes, perfect.
Okay, well, thank you so much, Odette, for your warm introduction and the kind invitation to join you this evening. I really feel it's a great privilege to join you to talk about this particular issue that is of great interest to me and has been over many, many years. As Odette said, I am very happy to take questions, and there will be a couple of spots during the presentation where I'm going to stop to have some discussion around what your experience is in your service. In terms of experience of implementing pain screening, I'm a clinician. I look after palliative care patients in a palliative care unit and have also in the past for about 15 years looked after a community service. So we implemented pain screening there, and we routinely screen. In terms of from research point of view, we've done some work around implementing electronic pain screening, and then as part of a large study implementing national cancer pain guideline in cancer centres around the country, we screened about 46,000 patients for pain and came across lots of benefits and challenges, which I look forward to sharing with you today. So just to start, to remind ourselves about what it is we're looking for here. What is pain? So the International Association for the Study of Pain have revised its definition just a couple of years ago. Pain is an aversive sensory and emotional experience. So a sensory and emotional experience typically caused by or resembling that caused by actual or potential tissue injury. They have 6 accompanying notes to the definition, and I just wanted to highlight one of them. A person's report of an experience as pain should be accepted as such and respected. Pain is entirely subjective. We can observe some responses to pain, but often in people who have chronic pain, the usual pain responses that you might see are heightened blood pressure, tachycardia, sweating, that sort of thing is no longer present. And so it really is entirely dependent on the patient, what a patient can tell us. What is screening for pain? So there's a number of ways of screening for pain, and we'll look at the different potential tools. It's really asking if a patient, if pain is present. You can ask if it's present now, or what the worst pain was in the last 24 hours, the average pain in the last 24 hours, or the least pain that that person's experienced in the last 24 hours, which are the 4 items of the brief pain inventory. You can ask about pain severity, how severe your pain is. For instance, on a 0 to 10 scale, where 0 is no pain and 10 is the worst pain imaginable, such as in the Edmonton Symptom Assessment Scale. And you can also ask how distressing pain is. That is, how distressing, worrying, or bothersome is your pain on a 0 to 10 scale, where 0 is not distressing and 10 is the most distressing imaginable. And this is getting at the idea that many people live with chronic pain. About 1 in 5 people live with chronic pain, and for many, that for them it is not troublesome. Why do we screen for pain? So there's good evidence. Apologies for the overlay here of the image to the content, to the text. There's good evidence for improved reporting of unmet needs and improved quality of life for those who are screened for pain. It's strongly recommended in international guidelines, and if you look at all international guidelines, which we have done in developing the Australian National Cancer Pain Guideline, we looked at all international guidelines that fulfilled a certain criteria, and it is a strong recommendation in all the guidelines. In the Indian national standards for palliative care, you can see that assessment and documentation of pain with at least the body chart and pain scale, and assessment and documentation of other symptoms is a standard. And so there's many good reasons why we should be screening for pain. So what tools can we use? The idea is really to use a validated tool, and a validated tool for your setting and your population. So I've got here, you can see in this image on the right that there's actually lots of tools together in one instrument, if you like. So at the top here, we've got 0 to 10, which is that numeric rating scale in the NRS. We've also got a verbal rating scale, otherwise known as a categorical scale, where people group those numeric ratings into none, mild, moderate, and severe. And there's a really significant proportion of people who struggle to use a numeric rating scale. And so a categorical scale is a more helpful way for them to express the severity of their pain. And finally here, this is a visual analog scale where it's really a line with 2 anchors, one with no pain, the other with worst pain imaginable. And a person can really draw a mark on that line to sort of indicate how severe their pain is. For those who have cognitive impairment, they may not be able to use any of those scales. And so a dedicated scale, such as the Abbey Pain Scale, would be an alternative. This is an image of the Abbey Pain Scale. I hope you can see that there. It really has 6 categories, which include vocalization, so sounds such as whimpering, groaning, and crying. Facial expressions, so how does the patient look? Do they look tense? Are they frowning, grimacing? Do they look frightened? A change in body language, fidgeting, rocking, guarding. And for each of these items, there's a score of absent 0, mild scoring 1, moderate 2, and severe 3. Is there behavioural change, more confusion, refusing to eat, an alteration in usual patterns? Is there a physiological change, temperature, pulse, blood pressure outside the normal limits, perspiring, flushing, or pallor? And finally, are there physical changes, which may be a cause of pain, pressure areas, arthritis, contractures? So you sum the scores to come up with a total pain score, where 0 to 2 is no pain, 3 to 7 is mild, 8 to 13 moderate, and 14 plus severe. And this can be a very helpful tool to use in those who aren't unable to express their pain. This is a FACES chart, initially developed for use in children, and then the use was extended to other populations. And you can see here, you know, that the happy face with no pain to the very distressed and crying face with severe pain. I wanted to introduce you to the Palliative Care Outcomes Collaboration. This is an Australian outcomes collaboration where all the palliative care services are benchmarked against each other in Australia. And you can see that the symptom assessment scale, which is a symptom distress scale, incorporates all those tools apart from the visual analog scale. So it's got the categorical scale, absent, mild, moderate, severe, the numeric scale, and the FACES scale. And you can see it includes a number of symptoms, and in particular, the pain is there, the last in that list of symptoms. This is the tool that we use in our service, and the data is captured electronically. Each day, the patient will fill out the form with the date at the top, so they have the same form throughout a week, and they will score their symptoms, which is then entered into our electronic medical record. And Chian will show us a case shortly showing how that's displayed electronically. This is the body chart that was mentioned in the Indian standards, and you can see that people can mark here where on the body the pain occurs. We know that many people with cancer and other life-limiting illnesses may have numerous pains, and so each can be documented and assessed thoroughly separately. I wanted to take a pause now and hear from you about what tools you're currently using in your practices. And Odette, if you wouldn't mind sharing and taking any questions or comments, that would be really helpful. It's a little hard with the presentation screen for me to see.
Sure. Thanks, Melanie. So can you see the question on the screen? And so Dr. Shri Devi's written that this is at Pallium, is it, Shri, that you tend to use a numerical rating scale?
Yes.
Okay. Do you use any of the other scales that Melanie mentioned for different populations or children or anything else? Or
so by and large, it is numerical rating scale, and if we have children, then Wong Becker FACES scale. We have very less child pediatric palliative care patients, so mostly NRS.
Okay. And I think, Melanie, did you see Dr. Cale's response in the chat?
Yes, thank you. Oh, it's nice to see that you're familiar with a couple of those tools I mentioned. Thank you so much for sharing what tools you're using. Okay, so let's carry on.
Thank you, Shilpa.
So when to screen and who screens? The Australian guideline, cancer pain guideline, suggests that we screen at each clinical encounter. So for instance, clinic visits and home visits, the suggestion is that we would ask each time what people's, at least ask what people's average pain has been in the last 24 hours. For inpatients, we screen daily or when there's a change in pain, and you'll see in our upcoming case where screening has been conducted twice because of a change in the clinical condition. There's some evidence from work conducted in the United States by Ethan Bash that if you screen people receiving cancer treatment on a regular basis from home, so they would provide their screening data electronically, that there's a range of improved outcomes, including better symptom control, less hospital admissions, better ability to tolerate chemotherapy. So I guess that's a question for us. In our service, we screen at clinical encounters as opposed to preemptively gathering screening data that patients regularly submit from home. In terms of who conducts the screening, the tool can be given to patients by administrative staff, a nurse, and or medical staff. And I'd be interested in if people have other ideas for who could administer the tools. Interestingly, administrative staff from time to time find that difficult to administer because when there's high scores and not ready access to clinical staff or immediate access to clinical staff, it can cause significant stress. There's some evidence that providing the tool by a nurse, in particular a nurse educator or a nurse practitioner who can act quickly to respond to high pain scores by starting to commence a comprehensive assessment, triggering immediate referral to medical staff is helpful, and then following up later to provide education to patients about pain management and in particular self-management tools. So I wanted again to include everybody by asking the question of how you might find screening helpful in your practice. I wonder if there's any comments or thoughts on that. Yeah. Thank you, Dr.
Kale.
Yeah, Dr. Kale, that's very, very helpful suggestion. The symptom assessment chart filled out by the doctor. Thank you.
And could I add, Dr. Kale, is that done every morning? Is that what you're saying?
Yes, every morning. Yes, I come every morning and reassess. And in the afternoon, one of my assistants, they do it. But once in 24 hours, I do it.
Okay.
Because I stay here for six hours only.
Okay.
And then, of course, I'm available on phone 24/7.
Right. Is there any other, would anyone else like to respond to Melanie's question about how helpful you find screening or when you tend to do the screening? I think, Melanie, you said you find it most helpful if it's done. I slightly missed it actually when you were saying that what you've found to work best in your service, that you don't just.
I apologise. It must have been.
No,
too quick. Yeah, so in our inpatient unit, the patient completes the tool each morning, and if they're unable to do it, they do it with the assistance of a nurse. And that we've found has been a really interesting exercise. It's important for the patients to be able to express the severity, or in our case, because we're using the symptom assessment scale, which shows distress from pain, it's helpful for the patients to be able to express that distress from pain. One of the interesting things we've found is that often caregivers or patient, family members of the patient will help them to complete the form or complete it on their behalf. And we've found, interestingly, that it's often the caregiver's distress that is reflected in the form. And so we have to be very careful that we're ensuring that it's the patient's voice that we're hearing, not the family member's impression of what the patient is experiencing. Is a very interesting conversation that can occur there.
Thank you. Sorry, and Dr. Kale, were you trying to say something?
Because see, when we interact with the patient and the caregiver separately and together also, there's a slight difference between, because the caregiver always thinks the patient is in severe pain, but when we interact with the patient, and they say, because I am evaluating every day, so what was the score yesterday? Suppose score was 6, I'll find out what is the score today. NRS, maybe 4, maybe 3. So, and we have to achieve at least 2. So caregiver, sometimes I have found with my experience that they try to escalate the score, which may not be
a bit higher. Right.
That is natural.
So that sounds like a similar experience across Australia and India then.
Yes.
Exactly what we find, yeah. And Dr. Sridevi has also made a comment there, thank you, that it helps with follow-up. That's a really great point. And we do find that there's very good consistency between ratings of an individual. So what an individual calls 6 out of 10 is going to be consistent over time. So that if we are seeing an improvement, that's very good evidence that there's response to the interventions that we're using. Very good, thank you. Excellent. So the next, I just want to share my experience about how I find screening helpful. It does open communication about pain and other symptoms. So it enables us to understand the severity and distress that's related to pain. It can trigger a comprehensive assessment, and we'll look at what to do if we find higher pain scores shortly. It enhances the therapeutic relationship because a patient will feel heard and understood. And it can lead to an accurate diagnosis of the cause of the pain, the mechanism of the pain, and guide our treatments. So what do you do if the pain is greater than or equal to 4? You would progress to a comprehensive assessment. I just wanted to commend to you the Australian Cancer Pain Management Guideline, which is updated frequently. It's accessible at the point of care via the internet at that link. And this is the summary of the clinical pathway for pain. And so you can see at the top here we have screening for pain and using the rating scale, Abbey Pain Scale, and then going on to a comprehensive assessment. There'd be a pain score or a change in pain. And you can see here that then there's recommendations for management. At the top here is communication with patients to educate them about causes of pain and self-management strategies. And then if there's on review of pain control, there's ongoing or new or unexpected changes, we go back to the beginning with another comprehensive assessment. So now I wanted to talk about ideas for implementing screening. It can be very complex to do it, and there's lots of factors that interplay. It was lovely to hear your experience there, Dr. Kale, of going in and doing the screening each day yourself. I wondered if anyone wanted to share their experience of implementing screening or some ideas for how to implement screening.
So Dr. Kale, you've talked about doing that on a daily basis using a paper system, is it? You write it on some kind of formal
there's a
chart
paper
or?
assessment. Yes, yes, daily. Every day, date is given. The physical assessment chart is a chart which is attached to patient's file. I'm talking of indoor patients only. I'm in charge of indoor patient, and so every day it's written. So yeah, and if in the evening there is a change, the evening doctor who is there up to 6 o'clock, he or she will change or modify that, and accordingly.
And do you, sorry to interrupt, do you have a dedicated form that everybody uses, or is it just written in the clinical note?
No, it is a daily chart. It's prepared chart. It is there before even I
Like on the observation chart or something, or?
It's a chart, assessment chart.
Yeah.
With dates.
Okay.
Yes, name, registration number.
Yep. Thank you. And Sri Debbie, I think you said the same. Is it? Can you describe how you do it at Pallium?
So in the initial assessment chart, we have numerical rating scale and the body chart. And for the subsequent visits, we have made the seal which has the body chart, so you can just put the picture on and then you can mark the area and score it again.
Okay. And Melanie, can you see Dr. Khanna's response?
I can. Thank you so much for that paper-based standardized form for
Doctor,
workers.
hello.
Just a minute, Dr. Kale.
Yes.
I can show you the chart. This is the
okay.
Lovely.
This is the physical
Wonderful. Thank you.
chart.
Oh, good. Maybe you can scan it and email it to us or WhatsApp it or something. That'd be great to share it with the group.
I send it by mail. Yes.
Okay. Thank you very much. Sorry, Melanie, you were saying.
Shilpa Khanna's comment here, the paper-based standardised form for community level workers because patients aren't able to administer it themselves here. That's really helpful, and it's just excellent to hear that so much pain screening is already going on across your services. So some of the challenges that we have come across in the various ways. I'm really encouraged to hear that you're considering electronic screening. It's quite a big undertaking to introduce electronic screening. Interestingly, in the pilot study that we did for the large implementation of cancer pain guidelines around the country, implementing the screening took up most of our resources. It was a big job. And some of the challenges that we came across and that you might come across too as you consider implementing screening or moving to electronic screening or broadening your approach to screening, your organisational support. So it's really important to get your senior managers involved and supportive. There may be resource considerations, but certainly getting screening as a priority for the organisation will help. Often there's lots of priorities that an organisation is juggling, and so to have that as a priority is good. There can be administrative barriers. It's lovely to hear Dr. Kale and also the community workers administering it. There's a number of steps in getting a pain form to a patient or to a bedside, and there can be barriers. There can be health professional barriers, so it may be that your community workers are keen to do it, but when you work in big teams, from time to time, there'll be health professionals who either have other things that they would like to focus on first, or actually won't look at the screening tool. So getting the health professionals who can act on the pain scores to look at them and consider a response to the pain score can be a challenge. As has already been raised, patients may find screening tools difficult, and there's lots of barriers to reporting pain, and I'm aware that I have seen data from lots of countries, but not really from India, about the different barriers that you might experience. But it's certainly in Western countries, stoicism, fatalism, fear of distracting the doctor from focusing on treating the cancer, fear of medication, so people may not want to use opioids, for instance, to manage their pain, so they may not mention the pain. I can see Dr. Kale's got his hand up.
Hello.
Yes.
Hello. Literacy of the patient may sometimes confuse. They get confused when we give these tools, and of course then we reassess. So it's sometimes difficult, but on an average that works. All the NRS and facial scales do work.
Yes.
And,
yeah.
And one more fear, what you have said, they try to exaggerate what it is there or not, so that they feel that the doctors pay more attention, which is actually their false idea, because we see the patient every day. So I don't think, but sometimes it happens, maybe 1 in 10, but on an average these tools work. Thank you.
Thank you for that feedback. That's excellent. I'd be interested to hear whether you have other barriers. That was, if I understood correctly, Dr. Kale was saying that people may report their pain more highly than it actually is in order to get the doctor's attention.
Right.
Yeah, there may well be other barriers to reporting pain.
No other barriers.
Yeah. Just checking that I haven't missed anything in the chat. Okay, and that was all I had to share today, but I'd be delighted to answer any questions that people have.
That's wonderful. Thank you, Melanie, and thank you for just recognizing that there are likely to be both similarities and differences across the different countries, according to so many factors, I think, around health professional relationships with patients and family relationships and education, literacy, all those aspects. But I really appreciate you also trying to hear from the group, and perhaps we can all participate a little bit more and respond to some of the questions that Melanie has raised, particularly, sharing barriers that you've encountered in trying to implement pain screening, because I'm sure what you've encountered may also, and the solutions you've come up with may be helpful to other people in the session. So, Dr. Kale, you've been sharing your experiences, which has been really valuable. Would others also like to comment whether you've been able to implement pain screening at some level and why you find it helpful and where you've struggled? I think that's the value of these sessions, that we really learn from each other. Otherwise, I might have to ask somebody, which would be really mean, but I'm tempted to ask you, Dr. Koshy, because you're a very senior clinician and I know you have an enormous amount of experience. So I'm wondering what your experience has been. All these blank screens with mute off, I'm just wondering if there's anybody actually there. So please put your videos on if you can, and we'd love to hear from you. Okay, thank you, Shilpa. The language is a barrier. Okay. So can you describe that? Is it trying to, or maybe Melanie, you'd like to comment on that, on Shilpa's reflection about the language that people use to describe pain. And also it's kind of that interface, isn't it, between the clinical language and the patient's language. And yeah, can you comment on what you would?
Exactly, because we've got things in our head about what we're
Sorry,
looking
I'll just
for.
mute. Could you mute Dr. Kale? There's a bit of background.
What we're looking for is indicators of the type of pain. So we're looking for, you know, aching, gnawing, that sort of thing for nociceptive pain. We're looking for, you know, stabbing association with numbness of experience or a painful experience to touch. So we've got in our heads, okay, this is what we're looking for. And pain is hard to describe. I don't know whether others have experienced it in their own lives, but pain is hard to describe. And sometimes giving prompts can help, but it's a fascinating thing just to listen to people about how they themselves describe the pain.
Thanks. There's another comment in the chat about screening is easy if the patient is on home care.
I'd love to hear a bit more about that. I don't really understand what that means, as that all the issues are covered in the patient's environment. Do you mean that the history is taken at home so they're feeling at ease, or that you've got systems in place to detect pain?
Oh gosh. Oh dear.
Odette, are you okay? You're not on mute there.
Sorry, I just dislodged the plug on my computer, so I can you hear me? There you are.
We can hear you. We can hear you.
So sorry, I just stretched my leg out and unplugged the computer in the process. Did Dr. Shabare respond to your question?
Not yet.
Okay, that's all right. That's all right. Sorry, I
Hey,
wasn't sure what I'd missed. Hello.
Hello, ma'am.
Hi. Can you describe that a little more? Yeah, we can hear you.
Actually, ma'am, we are taking patients on home care basis. Like we are providing them services on home care. So it happens like in patient's home, at patient's home. You know, you get to know about all the psychosocial issues, their mental issues, their physical stress, their mental distress. So it becomes more easier. You know the patient from its home. So it becomes more easier.
Yeah. And do you use a screening tool?
Sorry, ma'am.
Do you use a screening tool?
Yeah, we are having that assessment chart, which Dr. Kare showed you. We are from the same institute. So we use the same chart.
Mm-hmm. It's so encouraging to hear about the charts that everybody is using. Odette did some wonderful work, I'm going to say maybe 15 years ago, showing that pain assessments were more comprehensive in the presence of these specific pain charts, specific tools. So yeah, well done.
And also, I think, Dr. Shabare, you raised a really good point that, you know, as Melanie said, pain is a kind of whole person experience, if you like. And so when you're able to be in the patient's environment, maybe it is easier to get a sense of the pain in a way that you can't easily in a clinic or in a hospital, because you you are perhaps a bit more in contact with the whole person in their own environment, with their family around, with their personal life all around them. So that's an interesting observation, I think. And perhaps
I'm noticing that there's a few people who haven't shared yet. So if you are not screening in your service and you at all wanted to chat about it, I'd be so happy to connect with you. So please feel free. You can get my details through the team.
Thank you, Melanie. I guess in the interest of time, we should move on to our two case presenters. So I think first we'll ask Dr. Chan to present her case and then move on to Dr. Kale's case. So thank you very much, Chan. Thank you again, Melanie.
A pleasure to present. Yeah. I'm trying to share the slide.
It should be, it seems like it's possible. Okay,
yeah,
good.
Yeah, good. So it's my pleasure to present tonight a case from Greenwich Hospital. I have this lady, 65 years old, with a newly diagnosed cholangiocarcinoma with liver metastasis and also complicated with delirium and constipation. So take note that she had a background history of intellectual disability with epilepsy and she's non-English speaking. So she first presented to the hospital with a complaint of jaundice for 2 weeks duration. Further history showed that she complained of vomiting as well, associated with dark urine, and there's some history of anorexia and increasing lethargy for the past 2 weeks. However, there was no fever. And from the history, based on the family members saying that she had a chronic history of constipation. And back to 2 to 3 weeks ago, before the presentation to the hospital with jaundice, she had a fall. So on the first encounter, on the assessment, noticed that this lady was drowsy. However, she kept pointing to her left and right upper quadrant of the abdomen, indicating that she's in pain. She also winced a lot with movement and she appeared quite agitated at times. From her vital signs show that the blood pressure and pulse rate was normal and she's not tachypnic. She appeared quite jaundiced. There's no flapping tremor noticed. And on the clinical assessment, noticed that there was a large bruise over the left lateral chest wall as well as the flank. And examination of the abdomen showed that she had distended abdomen and guarding noted over the right upper quadrant with hepatomegaly. So this is the investigation that we got throughout her hospital stay. From the initial presentation, we noticed that she had significant elevated total bilirubin count with predominant in the direct bilirubin. And there's some features of obstructive hepatitis, and also other parameters show that she had normal renal function as well as the cell line. So there's, of course, after some intervention, the total bilirubin came down steadily and her conditions changed throughout her admission. So we'll look into what are the investigation that we had for her. So because of her pain and frequent complaint of this pain over the left lateral chest wall, and we noticed there was a bruise there, we did a chest x-ray. And from the chest x-ray, noticed that there was a fracture over the left ninth rib, which is an undisplaced fracture. And other investigation for her, we did a CT scan, CT of the abdomen, noticed that there was a stricture over the common bile duct and also causing some dilatations over the biliary tract. There's also a lobulated lesions over the right lobe of the liver, and surrounding it, there's some small other lesions over the liver, especially over the right lobe of the liver. So the conclusion of this CT showed that this lady, she's having some stricture over the bowel biliary system, which could be due to malignancy as well as their features of liver metastasis. So followed by the investigation and her clinical presentation, she had an ERCP done. And from the ERs, we noticed that she had a stricture at 2.5 centimeter in the common hepatic duct, also with upstream biliary dilatation. So from there, they did a brush for the cytology, which came back as an adenocarcinoma. So following this ERCP, she had this plastic biliary stent inserted. So her progress in the ward, she was also treated with IV antibiotics for E. coli bacteremia. And throughout her admission, we found that she had very severe diabetes, which complicated with hyperosmolar hyperglycemic state. And she was started on hydration as well as insulin to treat her diabetes. So we continue to communicate with the family members regarding patient's progress and also keep updating for the goals of care. Because this is the first onset of jaundice associated with pain, as well as this newly diagnosed cholangiocarcinoma, the family members were in stress. And throughout her admission to the ward, we frequently assessed her pain. And this was taken on the 31st of August when her pain was controlled with opioids. And this is the symptom assessment scale that we perform in our hospital. And during the transfer of care, we have another symptom assessment scale just before the transfer, which the pain score came down to 0. However, after the transfer to our center, we noticed that she had increasing in pain. And this lady, she persistently, she's not really in complaint of pain, but we frequently noticed that she was frowning and also there was furrowing over her eyebrow, and she kept pointing at the pain over her right shoulder. So these are the symptom assessment scale that we use. From the pain score, she was unable to score because of language barrier, as well as she was intellectual disability. We basically obtained the assessment from the family members and the carer. So these are the medications that we used initially for her initial presentation of the pain. We were using tapentadol and then followed by switching it to the subcutaneous morphine infusion. And after transferring to our center, we changed it to hydromorphone infusion, and we continue with some PRN doses of medication to control her pain. And for her constipation, we are managing with doxycycline as well as lactulose and giving alternate days of glycerol suppository. So looking at her psychosocial aspect, she's a lady with intellectual disability. She was previously independent before the admission to the hospital. She was able to help herself in feeding herself, in toileting, but she required some degree of assistance in assisted activities of daily living. And also she's living with her 92-year-old mother and sometimes assisted by her brother and sister who used to visit her regularly. And sometimes they had a carer at home. So she's Christian faith. She's not English speaking, and basically her symptom assessment, we rely more on the sister and the carer to translate for us. And sometimes she responds in words and phrases only with repetitive questioning. So we can't really understand her, and the sister and carer took some effort to understand her as well. So the main concern for these family members are because they were still in shock with the diagnosis and they need some time to sink in with the diagnosis. And basically the family members were very overwhelmed with the emotions. And they told us that they were not ready to disclose the diagnosis to the patient because worried that she will be in fear. And also the family members have some perception towards palliative care. They thought that once patient is under palliative care, patients, most of them, they can't return home. So this was the fear from the family members. And also they are in the sense that they're trying not to giving up on patients because she used to be a very well lady. She used to be independent. So they feel that if they choose palliative care, could it mean that they are giving up on patients? And throughout her hospital stay, the patients developed some complications and she eventually became better, and they are quite uncertain with the prognosis generally. So in summary, this is a 62-year-old lady with a newly diagnosed cholangiocarcinoma with a background history of intellectual disability and currently presented with nociceptive pain, predominantly due to the rib fracture as well as the right hypochondriac pain, possibly visceral in origin. And she's in hyperactive delirium. Multifactorial causes could be due to sepsis as well as some hyperglycemic state as well as constipation. And most importantly, she's having language barrier with us. So my discussion points today could be, what are the challenges in assessing pain, especially with those with language barrier? And then pain assessment in non-communicative patients like this lady, when she first presented, she was drowsy and confused. How would they assess pain for them? And how reliable are these pain screening tools, especially when we base on proxy reporting on the symptom assessment rather than the patient themselves? So these are the discussion points. And if there are any questions, I'm happy to answer. Thank you.
Thank you, Jane. Could I ask you what you found the most challenging in managing this lady?
I think we base on the family members for the pain assessment. And just like our discussion, sometimes family members tend to overrate the pain, even though patients look comfortable without much wincing, but family members will report that patient might be in pain. And the scoring system, we need to rely on them, and most of the time we need to rely on the same person rather than different person. So let's say a carer change every day, so it might be difficult for us to assess whether pain from yesterday and today is still the same. So I find it's quite challenging for us to decide whether is it a true pain. As we always say that pain is something that patient report, not really the family members report.
Yeah, no, sounds really challenging. Does anyone have any questions for Jan or any comments on the management? Anything you'd like to clarify? Dr. Kale? Yeah. Dr. Kale, could you?
Again, I guess there is some problem with your audio. I can't hear you.
Your sound has become very muffled.
Okay.
That's a little clearer. Yeah.
Relatives for assessment, it'll be all difficult. That's all.
Okay. Thank you. So Melanie, this lady had language difficulties, well, a different language, and intellectual disability and delirium, and was drowsy. Yeah, very, very challenging to do screening. I mean, other than using the proxy. But in your experience, is it possible, if we put aside the delirium, is it possible to, try and get a patient across the language barrier, across the intellectual disability, to actually reliably obtain their score using some of the scales that are available?
So given her intellectual disability and her communication issues, which pre-existed her drowsiness, this is a good case where using something such as the Abbey Pain Scale is a good option. So she was very clearly grimacing and very agitated when she first came in, and seeing that she really, as the pain came under control, she was there was no more grimacing, there was no more groaning, calling out. She was quite physically aggressive during her cares when she first came in. I actually saw her hitting one of the nurses, quite loud vocalizations, clear distress in her face, and all that settled down as her pain came under control. And actually, we were able to, you will have noticed in the speech driver that she'd been on some midazolam, which was addressing her combined, the agitation. She'd had multiple complications, as you saw, prior to admission, and was quite delirious. And as that settled down and her pain settled down, we were able to entirely withdraw the midazolam, and she's just on a small dose of hydromorphone now.
Yeah, thank you. So you can really rely on the behaviour as an indication, as a using the Abbey. You can rate that using the Abbey scale in some way. Are there any other questions for Chen? Or anybody had a patient that with a sort of similar sort of complicated kind of situation that's made screening very difficult? Or perhaps with the family, where you really are concerned about using proxy reports, and how you might have dealt with that? Okay, so Dr. Shivar is talking about needing time to observe and assess and get to know the situation. Is that why you would ask them to stay for the 3 days, Shivari? Dr. Shivari?
Yeah, ma'am. Actually, ma'am, what happens is sometimes the pain, it can get subsided through the night, and by taking some medication, it gets subsided. And when you see the patient in the morning, so he's not having pain in the morning, but at night he has experienced that pain, so he's not going to complain. But the relative who was suffering with the patient, so the relative can say that the patient was having pain at night. So for these kind of situation, we tell the patient to just come and get admitted with us at least for 3 days. So he's kept under observation, clinical observation by the doctors and by the psychologist also. So she can see the behavior of the patient with their relatives, that how they are behaving with their relatives at the daytime, whole day. So both the things are managed, like physical pain is managed by us, and for psychosocial pain, it's managed by psychologists. So it becomes an easy path. Okay, thank you, ma'am.
Thank you. Any comment on that, Melanie or Shen?
I kind of agree that, since language are different, we have language barrier, but the facial expression and the behavior are kind of universal for pain. So most of the people will behave the same with the wincing, grimacing, groaning, and these are the behavior that quite accurately indicating that patient is in discomfort and in pain.
Yeah.
Jan, thank you for that comment, Dr. Shivari. And yes, I heartily agree that a period of observation can be very helpful. I'm interested in your comment about the different roles for psychological and physical pain of the psychologist and the physician. And it's wonderful that you have access to a psychologist. Often going back to that original definition that pain is a sensory and emotional experience, that often the psychological situation is exacerbating the physical pain by reducing the threshold for pain, and our central inhibition of pain can be reduced when there's associated psychological distress. So it's so important to address those psychological issues that can be exacerbating the pain. So thank you so much for that comment.
No, very good. And Melanie, could I just also extend that a little bit and ask you, I know one of your key interests is also in looking at spiritual pain and I guess existential pain. So can you talk about how you at your service try to look at that and not measure, well, maybe measure that. I don't know if you use a scale.
Well, yes, thank you very much. That's a great question. So there's a couple of things that we're doing. At the moment, we're trialling as a national palliative care project in Australia, looking at a psycho-existential distress assessment scale. And that is asking questions around hopelessness, pointlessness, lack of meaning, desire to die, depression, anxiety. That's run by Professor David Kassane, and we're a test site. We're using that questionnaire in our service with mixed results. Some of the patients are finding it difficult emotionally and spiritually to actually answer such a series of negatively framed questions. We have, though, found that it has uncovered some really deep psychological and spiritual distress in a couple of our patients that has enabled us to really start some effective interventions, sort of spiritual meaning-based interventions for those patients. There are other screening tools that we use. There's it's called the pronounced FICA or FICA, F-I-C-A tool, which looks at people's faith, the importance of their faith to them, the community of faith, and how they apply that in their lives. And our pastoral care service, which they use. So we do routinely screen for spiritual distress, and we have thankfully a pastoral care team who will approach spiritual care from wherever the patient's spirituality lies. So there's no although our organisation is a Christian organisation, there's no it's really very much patient-led, depending on what their spirituality is and what's important to them, what strengthens them, what gives them hope, meaning, and sustains them in serious illness.
Thank you, Melanie. Thanks for talking about that as well. I wonder if we can now move on to the next case, and just thank you again, Shan, for your presentation. It was a very, very lovely case to discuss. Thank you very much. So over to you, Dr. Kale. We're looking forward to your case. Thank you. Dr. Kale, sorry to interrupt. Tips, is there any way we can improve the sound quality at all of Dr. Kale's presentation, or any? I'm not sure if others can hear him. Can you? No.
Dr. Kale, can you hear us?
Rajalakshmi, can you help me?
Yes, doctor, we can hear you now.
Next slide. Next slide. Yes. This is a case of 48-year-old male diagnosed with periampullary carcinoma with obstructive jaundice. It is called pancreaticoduodenal complex. Next. This presenting complaint will be discussed in two parts. One, when the patient reported from hospital in May 2020, that was a pain in the abdomen in right upper quadrant, nausea, loss of appetite, and yellow discoloration of urine. On this finding and complaints, he was investigated thoroughly, and the CT, MRI, ultrasound, everything was done, And then the patient reported to me, means our institute, in May 2022, after the initial treatment in 2020. And now when the patient came to me in May 2022, he had pain abdomen, backache, anorexia, and bilateral pedal edema. Next. The history of present illness. History dates back to May 2020, where he had symptoms as described above: pain in the right upper abdomen and yellow discouraging urine. So USG, ERCP, and PET-CT was done. And based on these reports, since he had obstructive jaundice, CVD stenting was done to relieve the obstructive jaundice. So just a symptomatic relief. An upper GI endoscopy was done and a biopsy was taken, and the report was well differentiated adenocarcinoma. And it is, since it's an inoperable case, only chemotherapy was started. Now the patient has, after this, there was a gap 2 years. The patient was having no jaundice, so he was okay with that. Now in 2022, he came to us. And now the patient has come in the month of May this year only from Rashtrasan Toxicology Cancer Institute, which is nearby our place. And the patient had the symptoms of pedal edema, and he had no jaundice, but he had pain, extreme pain in the epigastrium. So it was revealed that the periampullary mass did not resolve in spite of chemotherapy. That means chemotherapy had no much significant effect in reduction of the tumor. And patient continued to have pain in the abdomen and backache. Next. The examination finding, when I saw the patient, was pulse 100, blood pressure 110/78, SpO2 96%, temperature was normal, pallor was present, no icterus, bilateral pedal edema, and tenderness in the epigastrium only. Next. Sorry. So treatment and significance. In May 2020, chemotherapy was given and a tumor marker study was done. It was that a CA20 was more than 500 units, normally 0 to 37. Upper GI endoscopy revealed a mass in the periampullary region and the biopsy taken. Report well differentiated carcinoma. Now May 2022, patient had severe pain in the abdomen. So PET-CT was done again on 17/5/2022, which revealed that the periampullary soft tissue mass involving pancreatico-duodenal complex and the metastasis in the peripancreatic and gastrohepatic nodes stained in situ with pneumobilia. So the patient was again put on chemotherapy and was referred to us for pain management. Next. The patient, psychosocial aspect, patient is worried as there is no cure, because it was told by doctors that there is no cure for this because it is inoperable. And second was financial constraint after his death. Next. Patient was kept on capsule tramadol from RST and the pain was not controlled. So we put him on morphine, 10 mg 4 hourly, and the patient settled within 3 days, and the patient took discharge as soon as the pain settled. And said that he will come back on 16th of June 2022 to RST and will continue the management as that centers, maybe chemotherapy. Next. So main concerns were inoperable because these agents are usually inoperable. Second is no cure. Definitely it's known that periampullary carcinoma, when it's stuck, it is no cure. And worried about the financial problems in the family because he was the only earner and he knew his end is near. So that was the main problem. And the spread is inevitable because the chemotherapy did not affect the same extent as it was expected. Spread is inevitable and the patient will develop ascites and will need peritoneal tapping. This is what I told him. Next. Summary. A 48-year-old male patient diagnosed as a case of periampullary carcinoma, inoperable. Obstructive jaundice resolved due to stenting, but the response to chemotherapy is poor. Mild ascites, so the patient will need peritoneal tapping. If the patient does not subside, celiac plexus block may be considered. Next. Discussion point. What else can be done for this patient? Next is, what form of treatment can be advised in addition to palliative care? And what will be the fate of this patient? Next. Thank you.
Thank you so much, Dr. Kale. That's a lovely, crisp case and challenging as well for us all. I had to remind myself about pneumobilia. I presume everybody knows what it means.
Yes, sir. Yes, madam.
I had to remind myself what pneumobilia was.
Pneumobilia. Shall I take?
Yeah,
Pneumobilia, because when there is a stent in the CVD, gas from the duodenum will rise up because of this, and then it will be seen in the biliary tract. That's called a pneumobilia. That's a normal finding for obstructive jaundice. There is nothing abnormal. I am a surgeon, so I know all this.
Yeah, and that's right. That's why it was helpful to learn from you. So what happened to the patient's pain management? You put him on morphine, 10 milligrams 4 hourly, and did you just keep him on that same dose?
He is settled with morphine, and he's continuing with that. After that, for 2 months, he has not come. Maybe that he's taking morphine from somewhere else.
So he can access morphine?
He has not reported.
Yeah.
Only
okay.
morphine has settled him. And once he knows that there's no cure, he said once the pain is settled, he's happy.
Yeah, yeah.
And his mere problem was the financial constraint, which we cannot solve.
Right. No, that's true. Has anyone got any questions for Dr. Kale, or would like to address some of his discussion points? What else could be done for the patient? If what form of treatment could be advised in addition to palliative care? Are you asking if there's anything more interventional that could be done in that question? And then what will be the fate of the patient? Melanie, thanks.
Much for a very interesting case, Dr. Kale. I was wondering about how easy it is for you to access celiac plexus block, and what type or what method of block do you use?
I couldn't get it.
Could you catch that? So Melanie was asking whether you can access celiac plexus blocks and what method of block. I mean, what approach, I think.
I cannot do it, but the specialists are there who can access celiac access. The anesthetist.
So it's easy for you to access that, those specialists? Or is it financially difficult for the patients?
Financially, it is very costly.
So what proportion of patients that you look after could actually access it, do you think? Sorry, I'm wondering what proportion of patients that you see would be financially able to access a celiac block and an anesthetic?
Very little.
Very few.
Actually, that's
okay.
one of the technical, and that's just for discussion.
Sure.
For that is a different thing.
Yeah. And again, in this patient, perhaps there's too much disease around the celiac plexus, perhaps, to necessarily get a good block. Sometimes that, because he's got quite advanced locoregional disease now, I think.
Celiac blocks is suggested if the patient does not settle with morphine. And that too, again, you have to re-block it. It only stands for 3 months.
But to get a good block, they need to have, it has to be able to diffuse, you know, the local anesthetic. And sometimes if there's a lot of disease, it can't disperse adequately to get a good block.
Right.
I think they try to do it, correct me if I'm wrong, but that they try to do it a little earlier in the disease. Would that be right? Sometimes they do it at the time of surgery as well, initial resection or some.
It's not a permanent solution.
No.
It's not a permanent solution.
So what do you think the fate of this patient will be? That's a good question.
As long as he will survive, we will give him morphine and keep his pain under control.
What about other symptoms?
No, he had only pain in epigastrium because he has no jaundice now, and supported treatment in the form of nutrition, protein, because he has a pedal edema, hypoproteinemia.
Yeah.
That is manageable.
Yeah.
The main concern was
Melanie?
pain.
Thanks, Odette. I did have another question, and forgive me because it's not, it was really in response to your question about other symptoms, Odette. I was wondering how frequently you use pancreatic enzyme replacement therapy in people with pancreatic cancer.
Sorry.
I'm wondering how frequently you use enzyme replacement therapy, pancreatic enzyme replacement.
Pancreatic enzyme replacement? No.
No.
Like,
We don't.
yeah.
We don't.
Yeah. How about in other centers? Do people have a different clinical experience? Again, this varies a lot from, you know, place to place and setting of care, the resources available, all those things, how you would manage patients like this. I was also thinking about the ascites as well, and what you were able to do for that.
Ascites is a consequence of any intra-abdominal mass, especially from GI tract, and that is tappable. We do it regularly in our center.
Yeah. Yeah.
That's not much of a problem, not at all.
That's it. No, that's
a
easy.
regular practice. Yes, yes.
Do you do it under diagnostic
sister,
imaging, or do you just do it at the bedside?
Bedside. We get him admitted in the morning, afternoon the patient can go. Even my sisters are trained. My sisters have trained, I have trained my sisters. They can do it in my absence also.
Fantastic. I don't know if you're still there, John. Would you do an acidic tap?
Sorry?
I'm asking John, who's one of the senior nurses educator, but do you know if any of the nurses in Australia would actually do a tap, an acidic tap?
Peritoneal nurse can do, no issue.
Not that I'm aware of, Odette.
I think it's fantastic, isn't it? Yeah. So how you've trained them, have you, Dr. Kale?
Sorry, madam?
You've trained your sisters to do an acidic
Yes,
tap.
and of course they are doing under my supervision. I am there. Just wanted to, because they should
It's
get
great.
trained. I am a trainer. Basically, I was a teacher, so I have a habit of that.
Yeah.
I was teacher for 10 years, so I do that.
Yeah. Yeah. Sorry, John, you were saying you were commenting on that.
Yes, look, not that I'm aware of, Odette, but that reminds me, Dr. Kale's comments that when I was in Ahmedabad, one of the workers there, who was probably the equivalent of probably not even an enrolled nurse, had been trained to do venipuncture and did just about anything that an RN would do, even a doctor in some situations. So yes, he was a wonderful asset to the team there.
Yeah. Very good.
Hello.
Yes.
As he said, I will share my experience. When I was in Durgapur, I have trained a class 8 pass person and made him an OT room assistant by training him. That's all. It can be done.
Okay.
I have done it.
Yeah. Well, you know, needs must, as they say. I guess that no one's commenting on the fate of this patient, but I guess, you know, your case suggests that there's been quite marked progression of disease over the past 2 years, and that the patient is entering into a fairly advanced stage of his illness. In our setting, we would probably try and follow that patient quite closely, but what's your capacity, what's the ability to follow up a patient like this in your setting, to monitor and to to manage ongoing, development of new problems and symptoms and end of life care. Can you follow up a patient like this, Dr. Kale?
Yes, we'll follow the patient.
In the community or in the clinic?
No, clinic here, because that I am based in the hospice. That Dr. Shika, who was talking just now before that, she is going for the home care. Another doctor is there, Prashant, he is also going for home care. I hardly go for home care. Suppose my expertise is required, then only I go. Otherwise, I am stationed at the Snehanchal.
Yeah. Okay. All right. Are there any other questions for Dr. Kale or comments on the case? So I don't know if we've answered any of your concerns or questions, but thank you for presenting the case and sharing that with us, sharing your experiences with us. Thank you very much, Dr. Kale.
Thank you. I'll send that assessment chart to you by mail.
Yes, please. Yes, please. We'll share it with the group. Thank you.
Yes.
All right, everyone. It's nearly 10 o'clock our time, so 4:30 Indian time, I think. And as you can see, Raj has put up the link for some feedback. We really appreciate your feedback if you have a moment to look at that. And just a reminder, our next session is on the, pardon? Our next session is on the 8th, I think it is, of November. Yes, 8th of November. And we hope to hear a presentation about pediatric patients and some of the dilemmas around feeding in the pediatric palliative care scenario. So thank you all very much, and especially thank you to our presenters today, Professor Melanie Lovell, Dr. Xian, and Dr. Kale. We